question 8. So, Dr. Ejiro Gene, you can please have the floor. You have 10 minutes to present. Thereafter, we'll have our questions and contributions. You can take the lead, Dr. Ejiro Ogene. Thank you.
Thank you. Good morning, facilitators, senior colleagues and colleagues. I'm Dr. Arere Ejiro. I'll be taking practice question 8. Okay, so the question is, a 50-year-old titular who presented with features of CLD, hepatitis B surface antigen and hepatitis C antibody are negative. The first question is to mention things you ask in the history to determine the cause of the CLD. 2, what findings on the examination will help you determine the cause of the CLD? The third question, the man was found to have alpha-1 antitrypsin deficiency. What other condition could he have? Will a liver transplant improve his condition and why? Okay, in tackling the first question, I put up this slide showing the causes of CLD to try to eliminate the possible causes that the history given has already eliminated. They already told us it's hepatitis B and C negative. A titular is someone who never drinks alcohol. So that also excludes alcohol as the etiology of the CLD. So I highlighted the possible etiology for a 50-year-old male. So it is on this basis that I am answering the first question. So questions that I would like to ask in the history to determine the cause of the CLD. I will want to ask for possible features of cholestasis such as severe intractable pruritus. Has it been itching? Has there been a history of fatigue that may not be commensurate with the degree of illness? Is there a history of passage of dark-colored urine or pale bulky stools? Has it been passing oily stools that are difficult to flush? Is there a history of colicky abdominal pain or associated vomiting, which may suggest a biliary problem? Is there a history of unintended weight loss or exposure to moldy grains? Is there history to suggest neurologic features like drooling of saliva, speech impairment, swallowing difficulty, writing impairment, or mood disturbance, which may suggest Wilson's disease? Are there features to suggest respiratory problems like recurrent cough, which may be associated with sputum production, wheezing, dyspnea on exertion? Is there a history of exposure to cigarette smoke? Has there been a history? Has he noticed a history of change in skin color? By any chance, did he know if he had a developmental delay or hypoglycemic features like excessive sweating, palpitations, tremor, which could suggest a glycogen storage disease? Is there a history of diabetes, hypertension, or dyslipidemia in this patient, which would suggest metabolic dysfunction associated steatotic liver disease, or a family history of diabetes, liver disease, or liver cancer? So the next question is, what in your examination will help you determine the cause of the CLD? Okay, so if I examine the patient and I'm seeing presence of bronze or slate gray skin, it may suggest to me that the likely cause of the CLD is hemochromatosis. If on neurologic examination I find tremors, poor coordination, loss of fine motor control, gait abnormalities, or dystonia, and then on examining the eyes, I see Kayser-Fletcher's ring, cataract. It will suggest the presence patient looks obese with BMI, has abdominal gait since it's a male greater than 90 cm, or blood pressure is greater than 130, 85 millimeter mercury. It may suggest MASUD as the etiology of the CLD. Then for chest examination findings that will suggest COPD, such as tachypnea, hyperinflated lung fields, which I will get from hyperresonant percussion notes with loss of areas of normal cardiac and hepatic dullness. If the patient is in the tripod position with pulsely breathing, with pulsus paradoxus, that may suggest alpha-1 antitrypsin deficiency. And if I find presence of scratch marks, hyperpigmentation, xanthelasma, or xanthoma, that may suggest a primary biliary cholangitis. So they said, what other condition could this patient has antitrypsin deficiency? What other condition could this patient have? He will most likely have emphysema, COPD. Will the patient require a liver transplant, and why? Yes, liver transplant is a definitive and curative treatment modality for this patient because it's not only repairs the injured organ, but it also corrects the metabolic abnormality in this patient. In patients with alpha-1 antitrypsin deficiency, the problem mainly affects the lungs and the liver. And for the liver, the problem is that of a gain of function, and for the lungs is a loss of function. The specific role of alpha-1 antitrypsin is a protein that is secreted mainly by the liver, and it works actually to prevent neutrophil elastase in the lungs. So once there's this mutation in the alpha-1 antitrypsin gene, what happens is that glutamic acid is replaced by lysine on chromosome 14. On chromosome 14. And what happens there is that the alpha-1 antitrypsin, which ideally is secreted in the rough endoplasmic reticulum of the cell, undergoes some folding and ideally should be extruded into the cells. In the setting of the deficiency, what happens is in the folding, there's the mutation causes loss of sialic acid. So the folding is distorted. And so the alpha-1 antitrypsin is unable to leave the hepatocytes. So it accumulates in the hepatocytes and it's a mutant form. This eventually can lead to liver cirrhosis. And for the lung affectation, because alpha-1 antitrypsin is now unable to leave the hepatocytes, its usual role in inhibiting elastase in the lungs is also inhibited. So that's what leads to the emphysema. So, hello. Okay. So getting a liver transplant. Getting a liver transplant will not only correct this abnormality, correct the injury, but also correct the metabolic abnormality. Thank you.
Okay, thank you so much, Dr. Ejiro Ogene, for this extensive presentation. You're really well appreciated. So it's time for questions. It's time for contributions. Please let's appreciate her. Let's applaud her for her efforts. Thank you so much. So it's time for questions. It's time for contributions. Okay. While we wait for questions and contributions, okay, can you please go back to your first slide when you were answering your questions, like ruling out causes? Sorry. Thank you. Okay, so what exactly were you ruling out here when you asked for features of cholestasis, fatigue not commensurating with degree of illness, and then with dark colored urine, like the obstructive symptoms? What exactly were you trying to rule out there as a cause of CLD?
Primary biliary cholangitis, primary sclerosing cholangitis.
Okay, all right. Thank you so much. All right, so I'm going over to the chat room. So in the chat room, everyone is applauding you for your good presentation. Well done, Chief. Great response to the questions. Thanks. Everyone is applauding you so far for your presentation. We've not had any questions yet. So let me go if there's any electronic hand up. Okay, there's no electronic hand up. Everyone is appreciating you. So I don't know if any participant who is a gastroenterologist can add on before we move over to our chiefs. Okay, so there's a question here. Dr. Itonha is saying, please, what is the relationship between cigarette smoking and CLD? What is the relationship between cigarette smoking and CLD?
Okay. In answering this question, I mentioned we need to ask for history of cigarette smoking because of the risk it has in causing COPD. Because the common causes of CLD in our environment, yes, we know hepatitis, alcohol. But in the literature, I also found that once you've ruled out those causes, the next thing is to rule out presence of alpha-1 antitrypsin deficiency. And it is also alpha-1 antitrypsin deficiency actually has different phenotypes. The one that is implicated mainly in causing disease is the phenotype that has the Z allele. And once there is zygosity for this allele, yes, the alpha-1 antitrypsin levels are very low. Although in some literature, it is said that even with the presence of the homozygous allele, most people still don't come down with emphysema or liver disease, except there's a superimposed history of exposure to cigarette smoke. That's part of why I included that in asking about questions that we want to find out if to determine the etiology of CLD. I hope I've
Okay,
answered.
thank you. So, I think so. I think you've addressed it. Okay, so I have there's an electronic hand up. Dr. Muhammadu, you can actually ask your questions or make your contributions. Thank you.
Thank you very much for that nice presentation. I don't know, as you are ruling out some causes of CLD, I don't know, you have not gone to town with some drugs, history of drug exposure and also drug use. Then also other infectious causes apart from hepatitis B, because you limited yourself only to viral infections. You should also think about other tropical diseases that may likely cause CLD, hepatosplenic schistosomiasis and the rest. By and large, it's a good presentation. So those are just so in drug history, what should you be your target and how should you approach asking those questions?
Okay, drug history for CLD. And no drug readily comes to mind because the table I even put up there, I got from Schlesinger. Maybe you could help with the drugs. But no drugs readily, apart from paracetamol. Paracetamol will not cause a chronic liver disease. It will be more of an acute liver disease. Most drugs will cause acute liver failure and not chronic liver disease. That's why I also didn't emphasize drug history here.
Just thinking out, what about amiodarone that causes fibrosis to most tissues? Just thinking out loud. Amiodarone. Okay, somebody has even put it up right now. Okay, so let me go to the chat room.
In my mind, I was trying to see, because you went to town with some primary biliary cirrhosis, primary sclerosing cholangitis, and the rest. As a component of disease, statins, somebody even mentioned amiodarone now, some few antibiotics, and even nursing. So chronic illnesses with also history of use of drugs can actually be a pointer. It's just for you. You're just asking around. You may be surprised that some patient may be having some chronic arrhythmia. It was on amiodarone. The exam can go anywhere.
Okay. Thank you. I will include it.
Okay. So let me go to the chat room quickly. Okay. Someone is saying, could drugs be part of the causes, and what is the histologic findings, or what are the histologic findings of drug-induced CLD? Then the second question says, methotrexate, metaldopa, and amiodarone can cause cirrhosis. Okay, that's just an add-on, methotrexate and metaldopa. So now the question asked is, what are the histologic findings of drug-induced CLD? Okay. Dr. Ejiro, I don't know if I'm being heard. Dr. Ejiro.
Yes, yeah, I can hear you. Hello, can you hear me?
Yeah, I can.
Histologic findings of drug-induced liver injury.
Okay,
I'm
maybe
not
we can leave it.
very sure, but there may be some edema of the portal tracts. I think they are similar to what we find in other causes. Then some inflammation in the ducts as well. I may not be correct.
Dr. Dapo, do you have the answer to that question? The person who asked the question, Dr. Adebayo, do you have the answer to that question? Okay, maybe we'll wait when maybe a gastroenterologist or our chiefs. Okay, thank you so much. So somebody is asking, what is the final diagnosis for this patient? What's the final diagnosis for this patient? What's your top notch? As in, what's the topmost on your list for this patient?
I think it was a giveaway already. The third question, they told us the diagnosis. They said the patient was found to have alpha-1 antitrypsin deficiency. From the initial scenario given, if I should use this environment, I probably would not have gone for alpha-1 antitrypsin deficiency. I probably would have gone for a muscle D. But then we're not given enough features to even suggest that.
Okay, thank you so much. So there's a gastroenterologist that's about, okay, Dr. Justice Igbiti, you have the floor, please. Dr. Justice Igbiti.
Okay, good morning, teachers. Yeah, good morning, teachers and colleagues. Thank you very much, Dr. Kweju, for your presentation. So DILI, that's drug-induced liver injury, like you mentioned, could actually be acute or eventually result in chronic features, but histologic features are not specific because the different kinds of drugs cause different kinds of injuries to the liver. For example, you could have a cholestatic picture, zonal necrosis, hepatitis with or without cholestasis, massive necrosis. The point is, there's no specific histologic feature that tells you this is a drug-induced liver injury. It's dependent on the kind of injury caused by that particular kind of drug. But eventually, they will first start with an acute hepatitis, which will give you the picture for that kind of drug, and eventually result in cirrhosis. That's the point I was trying to make. Thank you.
Thank you, Dr. Justice, for that great input. So, we don't know, okay, just the last question. We don't know how the questions may go since we're talking about CLD. So how would you differentiate the physical signs or the clinical signs between alcoholic liver disease and viral hepatitis? Because, these two are the commonest. So how would you differentiate between alcoholic liver disease from viral hepatitis doing an examination on this patient, the physical examination on this patient? Do you have an idea?
Okay, is that still for me? Okay.
No, I'm asking the participants.
Their presentations are similar, but pointers to alcoholic liver disease, some of the peripheral stigmata of CLD that may be particular to alcoholic liver disease are parotid fullness, palmar erythema, and I think gynecomastia.
Okay, just to add on, for alcoholic liver disease, you cannot eat.
To alcoholic liver disease.
Okay, thank you. Just an add-on, for alcoholic liver disease, you can actually have micronodular lesion.
Physical examination.
Yeah, okay, are you done? Sorry.
If we want to get the liver functions, usually.
All right. Okay. We're not hearing you again. Okay. So just a quick one for for alcoholic liver disease, you can have micronodular lesions. Then for viral hepatitis.
Yes, thank you.
That's on histology. You said physical examination.
Physical exam. On palpation on the liver.
No, you cannot get micronodular thing on palpation. It's histology finding. It's a histological finding. You should be talking more of palmar erythema, duplicitous contractures, the loss of the hypotenuse antenna
eminences.
Yes, the eminences and all.
Okay. So for
You
palmar,
also have spider liver. The parotid fullness is really more for alcoholic liver disease.
All right. Thank you so much. Okay, so move over to our chiefs. Okay, so since
hello, Dr. Briggs, I want to say something. Can you hear me?
Okay, yes, I can hear you.
Okay, good morning, my teachers and colleagues. Okay, good morning, teachers and colleagues. I wanted to add something to the history taking. I remember those days when I was doing gastro. I know it's not really a common practice here, but we always ask, does the person eat raw fish? Just to rule out parasitic infections that can affect the liver. I think all those Paragonimus westermani things. So I don't know, but we usually ask it when we have a patient that has CLD. I know it's more common in Asia, but it's also part of our history taking when we do CLD history taking here. So thank you. That's what I wanted to add.
Thank you so much, Dr. Chineme. Okay, so move over to our chiefs. I think Chief Kara was already saying something. I don't know if she can continue with that. Okay, to our chiefs. Okay, Chief Christabel.
Oh, Chief Cookie, ma. Okay, go ahead, sir. Then we'll call Chief Cookie.
Chief Cookie. Okay. So you were calling the presenter was talking about Masudi. Please, could you call the full name, because not everybody that is a gastroenterologist. MASLD. What does that stand for? Okay.
Sorry, sir.
That's
it means okay.
Okay, go on. Go ahead.
It's metabolic dysfunction associated steatotic liver disease. It's the new nomenclature for non-alcoholic fatty liver disease.
That's fine. So that's why I'm saying you should mention, because everybody might not understand what you're saying. Okay. All right. So then the question about alpha-1 antitrypsin deficiency. You just said emphysema. I don't know. Okay, maybe the phenotype of COPD that it causes, right? But I was thinking that is also associated with bronchiectasis. Alpha-1 antitrypsin deficiency is not associated with bronchiectasis. Maybe the pulmonologist in the house can answer that, but I think it's also associated with bronchiectasis. Okay. From the knowledge I used to have, so that might also be something to mention. Okay, thank you. Those are just my contribution.
Okay, thank you, sir. I'm not sure of its association with bronchiectasis. I didn't come across that. So.
Okay, when glossing through, I actually saw bronchiectasis when I glossed through. So it's actually there. Thank you. Thank you so much.
Thank you.
All right.
I'll add it.
Okay. And I don't know if Chief Christabel, Chief Cookie, I don't know if we have more. Thank you.
Let us hear from Chief Cookie. She's the in-house gastroenterologist. 5 years post part 2. So let us just hear from
good morning, everyone. Thank you very much. Good morning. I want to start by commending Dr. Ejiru. She did a wonderful job. So when a patient comes with a liver pathology, so it's left to us to try to decipher if we are dealing with an acute liver disease or a chronic liver disease, So usually the cutoff is said to be 6 months. And more often with patients with chronic liver disease, they tend to have more of the peripheral stigmata because that has been ongoing. And of course, you have to ask all the questions with the possible risk factors, because as I said, many times, if a patient has already come in cirrhosis, it's quite difficult to even based on the histological based on histology, you rarely see much to have the underlying, to know what the underlying etiology is, and then in managing these patients, we still have to use the normal treatment for decompensation, because that's eventually what kills the patient, when the liver now decompensates, and then, the patient can either die from the complications of decompensated chronic liver disease or from hepatocellular cancer. So the decompensation is due to the portal hypertension and what have you. So I won't go through all the risk factors she said, because that's basically what the question was asking. So you need to know all those questions that you use to rule out. It's difficult to make a diagnosis of alcoholic liver disease if you haven't gotten that the patient telling you that they've taken alcohol. So you can also use the cage question, to also know that this person has been taking alcohol, that if they volunteer, they have, and then you can ask the cage question to now see that this patient has significant alcohol use. So the alpha-1 antitrypsin, the alpha-1 antitrypsin deficiency is one of the metabolic causes of chronic liver disease, but it's not one that is common in our environment. It's an autosomal recessive condition that is seen more in Caucasians, and when they now have that the homozygous gene, that's when they come down with the condition, and then you have them, when you look at the liver enzyme pattern, it has this cholestatic pattern, meaning that the direct bilirubin and the total bilirubin are both elevated, and you have the alkaline phosphatase and the GGT being elevated. So when you see that pattern, more than the transaminases, then you know that this is pointing towards a cholestatic pattern, and then the patient would have features of emphysema or even bronchiectasis, and then we know that this patient possibly has alpha-1 antitrypsin deficiency. So you also, since it's a metabolic or genetic this thing, so part of the investigation is to do genetic studies, and then also, of course, look at the nuclear family to see those who are carriers and then those who will come with it. So you also need to counsel them. So there's going to be genetic counseling, because it's something that can be passed on, if because they're autosomal recessive. So there's a 1 in 25, 1 in 4 chance of passing it on to children. And as we said, the most chronic liver disease, the absolute treatment for them is going to be liver transplant, because that would take care of any underlying abnormality. So that's just what I will add. Thank you very much.
Thank you so much, Chief Cookie, for that excellent input. We really appreciate it. Thank you. Okay, Chief Christabel.
We'll move to the next question. Chief Cookie, Ma, thank you so much, Ma.
Okay, thank you so much. Okay, so the next presenter is going to be taking us on practice question 7. So Dr. Cassidy Ibe, you have 10 minutes. You can please have the floor. Thank you.
Okay, good morning, teachers and colleagues. I'll be taking practice question 7 of the May 2024 fellowship exam. The question reads, illness could be categorized into acute, subacute, and chronic. In your own words, define chronic illness. Mention 4 top non-communicable chronic disorders in Africa, according to WHO. List 2 management models of chronic diseases and define them. And 4 said mention 10 things you need to set up a diabetic center. The number one question says, in your own words, define chronic illness. It can be defined as a long-term health condition that persists or reoccurs over time, often requiring ongoing medical attention and management. In other words, it's a long-term condition that lasts longer than 3 months, that may require medical attention, ongoing medical attention and management, may not have cure, but can be managed and may have the quality of life. Two said, mention 4 top non-communicable chronic disorders in Africa according to future. So the top 4 here are the cardiovascular diseases, the cancer, chronic respiratory diseases, and diabetes mellitus. List 2 management models of chronic diseases and define them. Number 1 here is the chronic care model, which is actually focuses on elements like self-management support, delivery system design, decision support, clinical information systems to improve healthcare practice and health outcomes. Number 2 is the guided care model, which is actually a new model for chronic care that is focused on the primary health care that is infused with operative principles of recent innovations to ensure optimal outcomes for patients with chronic conditions and complex healthcare model. 10 things you need to set up a diabetes clinic. Yeah, of course, you need a medical staff, which is a multidisciplinary diabetic team, where you would need endocrinologists, general care physicians, and nurse practitioners or certified diabetes educators, registered nurses, dietitians, even clinical psychologists, also podiatrists, even ophthalmologists also needed here. Then you have the facility, which where you need a dedicated space for consultations, examinations, and procedures. We should be equipped with necessary medical equipment. Like in our center here, we have a diabetic clinic days. That's actually have a dedicated place where those patients are seen. Then you have the equipment and supplies. Need your diabetes-related medications, insulin pumps, and supplies are also needed here. Then you have the laboratory services, where we have access to laboratory tests like glycated hemoglobins, lipid profiles, and point of care testing for glucose and ketones. Then there should be education and support where for education, diabetes education programs and materials, where there should be nutritional counseling and also behavioral therapy and mental health support. Then the administrative and technical support, which should have there should be electronic medical records and billing system, and staffs that are trained in diabetes management and education, and also certification and accreditation. There should be an accreditation from organizations like the Diabetes Association of Nigeria. Then we have this center also should be under insurance and for reimbursement, because at least to ensure sustainability. And then there should be a quality improvement where there have to be a continuous quality improvement processes, and you have to trace, analyze, at least some patient outcome and satisfaction. Then the last year is the community outreach, where there has to be a partnership with local healthcare providers and organizations. Then all this can be summarized using the 4X. We have the staff, the space, the stuff, and the system. So that's the end of the question. Then looking at a short overview, just a reminder of the differences between the acute, subacute, and chronic illness. You have the acute illness, which of most time is of sudden onset, usually lasts less than 6 weeks, and often treatable and curable. The subacute may be the transition phase between acute and chronic, lasting between 6 and 3 months. Then the chronic illness, like I said area, may have a gradual onset with long duration, often manageable but not curable. But these decisions, it's important to know that are not always clear-cut, as some conditions may overlap or transition between categories over time. Now, non-communicable diseases is also known as chronic diseases, tend to be of long duration. It may result from a combination of genetic, physiological, environmental, and behavioral factors, and they represent the leading cause of death worldwide, killing over 40 million people each year. The top 4 killers that together account for more than 80% of premature non-communicable disease death include the cardiovascular disease. We have the heart attacks, the stroke, the cancers, more notable here, the breast and the cervical cancer, respiratory diseases like the COPD, the diabetes mellitus, which make up 2.0 million deaths annually, including kidney diseases, deaths caused by diabetes mellitus. There has been a surge in the burden of non-communicable diseases in sub-Saharan Africa over the past 2 decades. This is actually driven by increasing incidence of cardiovascular risk factors such as tobacco use, healthy diets, reduced physical activity, hypertension, obesity, dyslipidemia, and air pollution, which can actually be grouped into the modifiable behavioral risk factors, metabolic risk factors, and environmental risk factors. Poverty is said to be closely linked to non-communicable disease because, as you all know, managing these conditions are very expensive. So most time, because of the economic situation, patients are not able to sustain those medications. Thereby, the outcomes most times are not favorable. And it's actually said that these diseases may overtake communicable maternal, neonatal, and nutritional diseases combined as the leading cause of mortality in sub-Saharan Africa. But it's actually said that non-communicable disease may threaten the progress towards the 2030 agenda for sustainable development, which include the target of reducing by 1/3 the probability of death from any of these diseases between the ages of 30 to 70 years. Now, looking at the management models of chronic diseases, is actually a structured approach to managing chronic conditions, which focuses on proactive and patient-centered care. The management of chronic disease has been a difficult challenge because of several factors, including lack of information technology in outpatient settings, multiple sources of unintegrated information, limited access to and use of specialists, including education services, and also time constraint. And this actually requires that patients take a more active role in the day-to-day decisions about the management of their illnesses. Therefore, the essential ingredients of effective chronic care management is the partnership between the patients and the health professionals, because it offers the opportunity to empower patients to become more active in managing their conditions. As when patients are informed, when they're involved and empowered, they interact more effectively with healthcare providers and strive to take more actions that improve the outcome of their conditions. There are actually a large diversity of chronic disease models that exist in the literature with many elements. Like I said earlier, the chronic care model, which actually is a model of care that designs the essential elements of chronic disease care. And it starts the improving chronic care will require continuous improvement in support for self-management, delivery system, clinical information systems, and also community resources to improve the health care practices and health outcome. Then actually this just illustrates the chronic care models. According to this model, where there's improvement in these processes, here you have the healthcare organizations, the community resource and policies. This will foster more productive interaction between patients who are, in this case, informed and activated in their care, and the practice team that are prepared and proactive in providing these cares. So ultimately, this productive interaction should improve the outcome of chronic care, including
Dr. Kathy, you have 1 minute left. 1 minute left. Thank you.
Okay, thank you. Then you have the Wagner chronic care, which is actually a more improved framework of this condition. They have the guided model care. The goal here is actually to have a model of care that is sustainable and diffusible throughout the healthcare, that should be effective in practices, valuable to healthcare organizations, and popular with patients and caregivers. This actually just shows the benefit of this guided care model. Then others are found in literature are the Stanford model. The overall aim here is to help the participant master 6 fundamental self-management tasks like resolving problems, making decisions, utilizing resources, and also making action plans for health behavior change and tailoring. Then here we have the transition care model. Here is essential for patients with complex care and addresses gaps in all care transition, including hospital to home, home to hospital, or physician office to home, chronic care to palliative care, and even palliative care to hospice care. As a take home, as I said earlier, non-communicable diseases are here with us, and it kills more than 41 million people each year. And these conditions, 70 million people actually die from this before the age of 30. And it's important that we know that important efforts are therefore needed to curb this burden of diseases in the region, starting with the provision of reliable estimates of these conditions and their drivers to appropriately inform prevention and control strategies. These are my references. Thank you for listening.
Thank you so much, Dr. Cassidy Ibe, for this very detailed presentation. Please let's applaud him. Let's appreciate his efforts. Okay, so we'd have questions coming in and also contributions. So while we await questions from participants, my only challenge is with the definition of the chronic illness, with the duration, because from your definition you made mention of 6 months and above. And there are some conditions like chronic stroke, they will say 1 month, chronic meningitis 1 month. So it's actually very. So I only have issues with the duration when you define chronic illness. So that's the only issue I have. Thank you so much.
Okay, like I said, there are not actually clear-cut distinction between some of these. It actually vary depending on the this is just the framework, is just to have an overview of what to have a better understanding in terms of the duration of some of these things. But it actually vary based on the conditions. Thank you.
Thank you so much. Thank you. All right, so going into the chat room, somebody. Okay, so Dr. Olalekan is saying, good morning. The following can also be part of the multidisciplinary team for diabetic care, where we have the podiatrist, the plastic surgeon, and then the orthopedic team. Thank you. Just like an add-on to the multidisciplinary team. Then every other person is commending you for a beautiful presentation. Dr. Yaya also talked about clarifying the duration during review. He has clarified. Okay. All right. So yes. So everyone is applauding you for a beautiful presentation. So I don't know if there's any electronic hand. Okay. So there's no electronic hand up. I don't know if we still have more questions or contributions. Okay. So in the absence of contributions and questions from the participants, we'll move over to our chief. Thank you.
Dr. Ibe, thank you so much. All your presentations, you've always done well. Thank you. Thank you. So please, can you go to the question again? I want to check something. Yes, I didn't hear you define acute and subacute. I was more, I don't know if you can define that clearly again. Maybe I missed it during the discussion. I'll just share more chronic. So what's acute or subacute?
Okay, actually, the question says in your own words, define chronic illness. You want maybe be trying to say it actually related to acute, subacute. But in my review, I actually met some definitions where I said the acute most times are of sudden onset. The symptoms may be severe, and most times they are actually treatable. The subacute may be a transition phase between the acute and the chronic, and most times it usually lasts between 6 to 3 months, and just a transition phase between these two cases and all that, acute and chronic illness. So I made that definition in the body or in my overview.
Okay, thank you. You are a senior person here already. So most times we just advise that once you are presenting any question, you answer the question in the question, so that as people go through, because during exam time, people go through these materials, they quickly go through the question. Most time you don't remember overview. So let the question after the question, the answer after the question. Then for the terminologies, duration will have been the definition is beautiful, really nice, but the duration will make sense. Acute, sudden, and the rest. A duration, just put a timeline to it. In case I know you're going for national, right? That's Ibe. Dr. Ibe.
Yes.
Dr. Ibe.
Yes.
We lost you.
Yes, ma'am.
Oh, you're hey, because I know
Yeah,
you're going
yeah.
for
Can you hear
national.
me?
Yes, I lost you. I couldn't hear you at the time. I know
Yes.
you're going for national exam. So please, duration is very important. Even though your definition is beautiful, still add a timeline to it. So that's just what I wanted to comment on. But overall, as always, you've always done well with your presentations. I don't know if our other chiefs, Chief Chitu is around, Chief Cookie, Dr. Remigus. I don't know if any of us have any comments. Okay. In the absence of any more comments, Dr. Deke, good morning. Long time. So, Dr. Deke, any comment? Okay, no comment.
Sorry, Dr. Christabel, this particular question, my network kept switching on and switching off. Was it talking about a particular disease entity, or were they talking generally?
It was generally asked him specific questions. What is acute?
Okay.
What is subacute?
Chronic,
What is
yes.
chronic?
Now,
it was quite straightforward.
Yes. So your comment about giving it a timeline. Well, it's difficult to give a generalized timeline for acute or for chronic and things like that, because it depends on the organ system that's involved. For instance, in nephrology, we say chronic starts at 3 months. Or in gastroenterology, if I'm not wrong, they say 6 months. So depending on, as when you're talking about the liver, they say 6 months. So depending on the organ system. But an easy way to sort yourself out is that acute is basically given to the time taking for you to actually see dysfunction in that organ system. So for instance, in my specialty in nephrology, if you say acute kidney injury, you're talking about something that happened over hours to days. By the time you're talking weeks, then you've left acute and you're, entered a new entity. Okay. And of course, by the time it hits 3 months of that continuous dysfunction, then you say there's chronic. Now, you will say that there are chronic changes to an organ system when there are certain histological changes or when there are certain histological changes in that particular organ system that are no longer reversible. Then that is when you say something has become chronic, meaning that thing is going to stay. All right. So easy way to put it is acute is when you start having any form of dysfunction in the organ system. Right. And chronic is basically when you start having histological changes that will persist and are no longer reversible. And then subacute is basically anything else in between, so to speak. All right. So that's an easy way to just stick your head out of it. But it may be difficult to give a timeline if you're talking generally. Okay, because it also depends on the organ system that it's involved. Yeah, that's just what I wanted to add.
Okay, sir. Let me pause recording so I'll see what I want